Thank you so much, sir. As we all know that one of the most challenging complication and a nightmare for the arthroplasty surgeons is dislocation. And to address this issue and provide us with the insightful presentation, I would like to welcome Dr. Kazim Rahim.
Assalamu alaikum everyone. Rahim. It's indeed an honor and privilege to back to my own institution. I have been the student of St. Medical College down 2000 and I did my house job from the same institution, JPMC. Now the things have really changed. We have got more challenges, of course, but I'm so much pleased and even thankful to the people of doctors who are working over here. They are putting their every effort to bring up the standard of the healthcare in our part of the world for the people of Pakistan. Thank you very much once again. So I will be just talking about the dual mobility cup in primary THA. When and why? That's what we always have to be very much clear in our mind. In dual mobility, what are the benefits, what are the pros, what are the cons, and what will going to help us to get the better outcome in specific group of the people. So this is the nightmare of any surgeon who does an arthroplasty surgeon. That's a dislocation. So we all are very much concerned when we do a total hip, and the first only thing that we are always looking forward in prayer, the post-operative, we doesn't see anything coming, the head is outside the hip. Or the patient coming to the OPD and say, okay, now my limb is shortened, is externally rotated, I'm feeling a pain. So that's where we always are concerned. There is no dislocation. So what are the causes? First, of course, the primary cause is the surgeon. Always remember, if there's a dislocation, most of the related complication or associated problem is because of the surgeon peroperative, or he hasn't placed the cup, placed the implant appropriately, so that later on had lead to the dislocation. So remember, while doing a trial, if your cup, if your implant is dislocating, it will going to dislocate later on. So it's nothing like a soft tissue that you will going to say, okay, iske abductors ko zara tight karke bandh do. That will not going to help, trust me. The thing that's always going to keep you happy, make sure your trial implant, or while you're doing at the end of the day when you are on the table, putting your leg in the external rotating of the patient and see if it is stable, that's mean the patient will again going to be having a stable hip. There the other reason also, that the reason of the patient also, there are some conditions. We will going to discuss about it. What are those conditions which might lead to the dislocation? And of course, whenever there's a dislocation, so what happened? There's a 3.4 time increase in the mortality of the patient because to encounter this problem of dislocation. Let's see what does the registry say. This is for us and as an arthroplasty surgeon, our whole of our discussion, thoughts, knowledge come mostly to the registry. This is Australian registries, and it has been proven it's the second common cause of revision arthroplasty. And it goes to 22% of the cause of the revision arthroplasty. It's a big. First is an infection. Of course, the most ancient and the most first registry that is being formed in the world was a Swedish registry, and it also shows the most common cause of dislocation is, and the most common cause of revision arthroplasty is first, if of course aseptic loosening. Second is also the dislocation, and goes to 15.9%. So this is a major problem for those revision arthroplasty surgeons who deals with this type of complication. So how this dual mobility evolved? It started with 1974, first time by the Gillies Basquiat, who introduced it. But there was a complication by the name of intraprostatic dislocation. The head is being dislocated from the polyethylene. So this is one of the most common dislocation. And then when it's come into the second generation, they overcome this problem with the high cross-link poly, and it is better placement of the head, and that's related complication has decreased. Now we have a third generation. What does this third generation has? This has a high cross-link poly, and that's even there's a modular option even in it, in which you can increase the size. So what is the basic principle or essence of using the dual mobility for us as an arthroplasty surgeon? This is the whole of the essence of the dual mobility. Increase the jump distance. If you see, there is a head that goes into the polyethylene, and it is snugly fit into the polyethylene, and the polyethylene goes into the another metal. So this, if you see this point where the plus is being marked, so this is goes with the jump distance. So we are increasing the jump distance. The more we will going to increase the jump distance, there's a less likely or decrease in the size of chance of dislocation. So very important aspect, we increase the jump distance. And another aspect, what we did, we increased the head size. So the head size of the cross-link polyethylene of 54 mm metal cup, that is around 47. So 47 head size you are putting inside the acetabulum. So that's, you can imagine, like increasing the head size, increase the what you can say the jump distance. The increase the jump distance will decrease the chance of dislocation. So this is whole of the concept, what the dual mobility is based on. So that's what we have discussed about it. That is the concept of jump distance. So previously, Charlie used 22 head, and there's a more chances of dislocation because the jump distance was less. There's an impingement, and the patient has a more chances of dislocation. With the passage of time, the head now standardized is increased to 28. If you're going to have a larger acetabulum cup, you can increase the acetabulum, this head, that will goes to 32. So 32 head is decrease the chance of dislocation. So this is whole of the concept that what we try to decrease the chance of dislocation in total hip replacement. So of course, with the use of highly cross-linked polyethylene, it has decreased the wear rate, and the survivability also have increased. There, what we have talked about the intrapelvic dislocation. So the head is pop out from the acetabulum component. So this was one of the complication of dual mobility, which is being now addressed in the third generation of implant. So now next question, when to use dual mobility? So these are all of the related indication that you have to keep in mind. Elderly patient, more than 75, because of the poor abductors muscle tone, there its relative indication is use of this dual mobility. Neurological disorders in which Parkinson's syndrome, stroke patient, and dementia patient, where you want to have a more stability, the dual mobility can come into play. Abductor deficiency, these patients who goes in multiple surgery, re-revision surgeries, where the abductor we know it's now functionally not competent. So here dual mobility will have some impact to prevent the dislocation. And high demand patient who want to have a full range of motion, in this the dual mobility come into play. So current indication, the safe zone in many part of the Europe, they are primarily using in the primary total hip replacement in the patient. And then they have shown in France, the literature, they have a 30 years of followers of using of dual mobility cup. And then they show the dislocation is less than 1%. So that's what that's why they are using in their primary hip even in most of the patient. So one of the few of the patient on which they have bamboo spine with ankylosing spondylitis, that we know the normal curvature is not there, the spine doesn't compensate with the sitting and the standing. There's a more chances of dislocation and here you can use this dual mobility cup. Displaced neck of femur fracture is been shown. There's a more chances of dislocation in standard cup, and here you can use a dual mobility. We have talked about the abductor insufficiencies. These are the patient with the revision hips, and then these are the patient, most of them with neurological symptoms. So dysplasia hip, where you have where you have to use a small cup. Here you can, with the help of this dual mobility, you can decrease the chance of dislocation and post-trauma patient as we have discussed right now. So now we have a two type of dual mobility that cup we always have. One is monoblock and another is modular. So in this system that we have right now, these are the modular. So there's a conventional cup. We use a metal poly. We put a metal line inside it. Over it, then we put polyethylene, and then we use it as a dual mobility. But if we see the previously that we have the implant that we have, the French implant that we have, they have the specific this DM metallic shelf. It was more deeper, and the poly that was used, that was an increase in the size. So that was the difference between the monoblock, the previously the most of the French that use, and the modular that we have right now. So of course the standard is same, the principle is same, approach is same. How you have to place the cup, we have talked about that since morning. I will not going to go into details. So you don't have to avoid or go against any principle while putting a dual mobility cup. So if you've seen the dislocation rate in those patients in which the standard THA is normal is less than 2%, that is acceptable. In those patients with the high risk patient, if standard total hip implant is being used, the dislocation goes to 8.2. These are the patients that what we have to account for the use of the dual mobility cup. And that's the dislocation goes to less than 0.5%. That is more acceptable for us. So adult patient more than 75 and dislocation rate, that what we always wish to achieve, and survivability is 99%. So if we summarize the whole of my lecture, why? To prevent instability. That is the second most common cause of revision total hip arthroplasty. That's what we want to prevent it that to happen. When we have talk about it, elderly patient, revision surgeries, and of course patient with the neurological disorders, and how the principle of the total hip, that what you have to do. So this was about whole of my lecture. So we have this, we had done this with the help of a navigation assisted total hip. We have done one case, and I will going to take you through the whole of the case, that how we did it, what was the advantage of using this navigation assisted total hip replacement. So this was a 61-year-old female who had polytrauma 5 years back with the right acetabulum fracture. It was a bicolumnar fracture, and then she had a distal femur fracture, left radius ulnar fracture also. Subsequently, patient underwent a right acetabulum ORIF, distal femur ORIF, and left radius ulnar fracture. So the patient, everything was uneventful. So when the patient currently present 5 years down the line, this was the present condition. If you see, the hip have went into the osteoarthritis because of the acetabulum fracture. Distal femur has been healed, radius ulnar also has been healed. So this is a scanogram of the patient in which you can appreciate about the osteoarthritis of the hip. So right hip, post-traumatic osteoarthritis. So why we should be using the navigation control system? What was the advantage that we gain by using this system. That's what I'm going to take you through it. So we did a CT scan preoperatively, and we had the whole of the information is been sent to the company, and this was a CT scan images that we have. If you can see, this was the whole of the CT scan images. So in the pelvis, the cuts, it should be less than 0.5 mm. So this is the cup that is being advised by the company that should need to be sent to them. So this was the 3D, and this was the whole information. If you can concentrate, they are advising us the cup, where the cup should be placed over here. Inclination should be 40 degree, version should be 20, and coverage around 72% we can achieve. And this was the cup that what we have to achieve. And in the transversely, this was the anti-version, that's what can be achieved. And that's the most important information. There will be a screw on our way. So pre-operatively, we had the whole of the plan, so how to address it. We had the cutter, we had all the instrument, we want to cut it, because we had done the SWM fracture fixation through the STOPA technique. So this was one of the options, to go anteriorly, open it, bring the screw out, or while doing a THR, we can cut the screw and we can address it. So pre-operative planning, it was a most important aspect that we able to address this problem. So coronal, transverse, and that's pre-operatively you have whole of the information. So stem, femoral planning, this is what the stem they have advised. And then that's what we have achieved. The limb-length discrepancy, -4 had that what we have. Global difference between the two was 6. So we have 2 mm that what we have to control. Pelvic tilt, what we able to, which we could be having a -5 degree. So at the end of the day, when the surgery is done, that's what you can have the 50 mm cup, stem CL size 2, 135 of the neck shaft angle, and femoral head, that what we have to use was -4 to achieve the limb length discrepancy. So here you can have pre-operative planning how to address the limb length discrepancy also. So here, that's what we have the whole of the information while we are doing the rimming. So the green zone show the bone that need to be rimmed. So once you have start rimming the green bone, when it started to be white, that means you have done with your work. So once there's a white and you started to have the red zone, red means you have to stop. So that there is a subchondral bone, and then there will be an issue. So the green, while putting an implant, the green is the reference point, and blue, what you're trying to put the implant inside. So green should, this blue, your implant should overlap the green one, so that your implant should appropriately be placed as per the preoperative planning. So this was the few of the reference point that what you have to take before the rimming, so that we make sure your rimming can be correlated with the program. So this is one of the beauty of this surgery, placement of the screw. So you have peroperatively whole of the idea where your screw should be placed. So with the help of a sensor mechanism, here you can see it is now been reading about the screw where it is being placed. Once you have taken the place where your screw want to place, so here this was the point you want to place to take your screw. So now it is going to show where your screw direction will be, and it will be just anterior to the sciatic notch. It's not coming anterior, so you will be able to see the safe zone. So, and then you can at the peroperatively you can change the direction accordingly, so you are in the safe zone, you are not in the sciatic notch, you are not anteriorly coming out of it. So here we have seen, and then here we have able to have the measurement of 30 mm screw that is being safe will be placed. So then we are going to drill it, and then at the end of the day screw we can place inside. So this was a post-operative X-ray, that what we achieved as per our planning that we have. And this was a post-operative report. So what we achieved peroperatively. This was also the post-operative report. We have all of the information about the implant, about the direction, about the limb-length discrepancy, and this is the patient that is first post-operative day. Thank you very much.
Having done dual mobilities over the last few years, we have published our initial results also. And the only comment would be, it's no doubt very good implant to salvage or prevent rather dislocations, which is our enemy in DHR. And just to emphasize the point that we have had some dislocation of core mobility also. So it's not immune